Who else has the papers? Chris, stop with the paper. You still have your
Well, I
paper?
don't want to piss you off.
Hand
I'll
in
make
that
a crack
paper.
on it.
For goodness sakes. Oh, you know what? I forgot. Do you have their, I have your, you don't mind waiting, guys, tomorrow for your practical exam? Do you need them today?
I need my lab nurse back.
I know, but we only gave them back to the lab that was there today.
Right.
No, I got nothing.
Do you want me to go get them or you know? Show me the key to your office. That's the problem.
All right, do
I'll
I
go down
have,
and see if I can find it.
do I have everybody's exam? Yes? All right, so you get an idea how the exams will be, how the tests will be, the quizzes will be. Yes?
Yeah.
All right, everybody's, do I have everybody's quiz?
Everyone turn it in?
All right, so what are the dermatomes of the upper extremities? What are the dermatomes of the upper extremity? Anybody?
Is it? Okay, so
Hold on, I'm just getting my boards together.
yeah, this is the trunk. Yeah.
What are dermatomes of the upper extremity? There's C4. Where's C4? Where's C4? Can anybody point to C4 as I look around? I'm not picking on you independently, okay? Because I'm not going to embarrass you, although you guys should have looked at this for this weekend, right? Where's C4? Where's C5? Where's C6? Everybody give me C7.
No, not doing that.
C8.
I'll give it to Kyle.
C8, T1, T2. All right, what are the rest of you doing? Do you all understand that this is something that you need to know? Do you all understand that?
Yes.
Do you all understand that this is important? Did yes,
It said T2. It's part of the extremity.
yeah, T2,
So this is T2 right here?
yeah. Okay, so everybody understands that it is important to know where the what are dermatomes? Ashka, what are dermatomes?
Regions of skin with sensory innervation.
Yes, exactly. Did everybody hear that? Because you all should understand that it is important. Why are these things important? These things are important just because I say they're important?
No.
No. These things are important because it's something that you're going to have to do when you assess a patient. You can't just guess where their problem is. What is an HNP? And what is the mechanism of injury for an HNP? Flexion and rotation. Where are the most common HNPs for?
And adherence to the CDC's COVID-19 guidelines when you are in the building. Everyone must wear a face mask at all times in public areas of the building. Everyone should observe social distancing, which is 6 feet apart. There should be no more than 2 people on an elevator at any one time. Everyone should wash their hands frequently, and if you feel ill, please stay home. Thank you for your cooperation.
for the cervical,
Please. Our college's coronavirus task force needs everyone's full cooperation and adherence to the CDC's COVID-19 guidelines when you are in the building. Everyone must wear a face mask at all times in public areas of the building. Everyone should observe social distancing, which is 6 feet apart. There should be no more than 2 people on an elevator at any one time. Everyone should wash their hands frequently, and if you feel ill, please stay home. Thank you for your cooperation.
okay, so for the cervical spine, the most common, things associated with, or the most common levels,
C5, C6,
are you
C6,
comfortable
C7.
with me being far enough from you? Because otherwise I'll stand behind there. Yeah. The most common levels are, I can't because I have to do that. C5 and 6, between C5 and 6 and 6 and 7, right?
Yeah.
Okay. So when we test the dermatome, we're looking at the area of skin that's innervated by those specific spinal nerves. So C4, C5, C6. So if I were to touch somebody on the lateral forearm,
C6. C6.
Dawn, on the lateral forearm, what am I assessing? C8? On the lateral forearm. Now, anytime we say lateral medial, what do we have to refer to? The anatomical position. Okay, so this is the anatomical position. Where is my lateral forearm? By my thumb or by my pinky? By my thumb. So if I'm going to use a pen or a wheel, and I'm going to assess for sharp or dull on the lateral forearm, what level am I assessing? Dawn, are you whispering? Because I can't hear you.
She said C6.
She said C6.
C6.
Okay, that is correct. If I said medial forearm, what would you say?
T1,
Rod
T1.
Neal, where's Rod Neal? What would you say? C8. Good. So that's given me some information about if they don't have if they have a sensory deficit in those areas. If I'm going to look at the cervical spine, this is where I need to go to. All right? It's not always 100%. The place, as is evidenced by some things we'll talk about later on, when we talk about the pronator teres syndrome, we talk about carpal tunnel syndrome. These are all things associated with median nerve problems, but as we know, a median nerve comes from what? C6 through T1, right? So we can go to the cervical spine, but we could also go to other things to assess where the problem is if we rule out the cervical spine. So R/O means rule out, right? You remember that from your abbreviations. So if we're going to rule out a cervical spine, we're going to have to look someplace else. So where do you think, if it's not coming from the cervical spine, we can go to? Probably the brachial plexus, right? Giving you kind of an idea, maybe? And then from there, moving down and seeing if it's just a localized thing somewhere in the arm. Upper arm, lower arm, wrist, fingers, etc. Okay? So, what is the capsular pattern? What is the capsular pattern? Wait, I got two of you guys. I'm drawing a blank here because I'm thinking of something else. You and you, your names are first?
Brian.
Brian's, that's right. One with an R, one with an I. Brian, what's the capsular pattern of the shoulder?
Yours greater than IR.
External rotation is limited greater than abduction, which is limited greater than internal rotation. Capsular pattern of the shoulder, right? Important, you can hand them out. Important information because we would have to know, is it something that we need to mobilize? Do we need to go to the capsule and do this, or is it just maybe some muscle that needs to be stretched, which is different from stretching a capsule? Those of you who remember looking at the video the other day and saw that there is a capsule that has a lot of redundancy And it's there purposely because the glenohumeral joint needs to have a lot of movement. So if it was restricting your movement, you would not have a lot of movement. But, however, if the capsule becomes tight,
Brian,
there are ways that we need to mobilize the capsule in an anterior direction, in a posterior direction, in an inferior direction, in a superior direction, in order to gain more movement. You will learn later on that when we do joint mobilization for the shoulder, in order to get flexion and internal rotation, we're going to move it in a posterior direction. And to do extension and external rotation, we're going to move it in an anterior direction. So that glide is associated with that concave-convex rule,
Isaiah,
which on your quizzes stated that if the movable bone is concave, we move it in the same direction we want we want it to go. So if we want it to go up, we move it in that direction. If we want it to go down, we do an inferior glide, et cetera, et cetera. Okay? So everybody's good with that?
So when you test the capsular pattern, if there's any
Monica?
limitations in any of those areas, ER, abduction, IR, that's how you know that there's an issue with the capsule.
Correct.
But
And-
if they're all
and
functioning within normal
And
limits-
every joint has a capsular pattern. Right now, we're just talking about the shoulder.
Okay.
Yes.
Is it different for every joint?
Yes. Yes. Which makes it a little bit harder to remember, but,
Andrew,
you know, if you do it often enough, you'll remember it.
Right.
So right now, you're just learning it. Okay, so the most restricted movement then would be, or in that capsular pattern, the movement that would be tightest would be the internal rotators, right? Okay. And Chris had a question regarding the last exam. I had new bones out, which were real bones. So the real bones I had out were a little bit different, because in the plastic bones, they really magnify things and they blah, blah, blah. The answer, and I realize that a lot of you guys recognize that marking or that upraising as a gluteal tuberosity. Gluteal tuberosity, in fact, is under or proximate to the greater tubercle. And the pectineal line is more approximate to the lesser tubercle. And I realized that it wasn't you, but one of the people that were labeling it put it on the pectineal line in lieu of the gluteal tuberosity, instead of the gluteal tuberosity. So what we did is, if you gave us either or, we gave you the points for it. Okay, so pectineal line is closer to the lesser tubercle, and the gluteal tuberosity is closer to the greater tubercle. Okay? The other thing I did for that exam that you had is, if you got part A wrong, but part B correct, I didn't take off for both parts, if you see. Okay? So, that I did give you. I mean, if you just misidentified something, but you answered the part B correctly. Did you see that, Andrew? Okay. I don't want you complaining to me. Saying you want 2 more points.
you need anything else?
No, thank you, thank you. All right, so, that should cover that, right? All right, glenohumeral movement, what is scapulohumeral rhythm?
1 to 2.
Rich, what is scapulohumeral rhythm? Get up and be heard. I want to hear you. What does scapulohumeral rhythm mean to you? You don't know. What'd you guys do after you left here Thursday? You figured you had your exam and that was it? You were done? And never more do you need to read? I'm telling you, right now we're doing muscles, and this is going to separate the boys from the men. I'm telling you. Because muscles are not easy. Even though it's memorization, it's still not easy. And you have to keep up with everything else. We move quickly, because we have to. What is glenohumeral Rhythm. Something you practice in birth control? Oh.
So,
Jade, you know?
I know it's 2 to 1, but
It's a 2-to-1. All right. Casey?
the first 60 degrees occurs at the humerus, and then from there, for every 2 degrees of movement of the humerus, it's 1 degree of the scapula.
All right, so basically it's a 2-to-1 ratio, right? For every 2 degrees, the humerus moves, the scapula moves 1, right? So we have 180 total degrees of scapulohumeral movement, or of humeral flexion and abduction, etc. Some of those degrees are for glenohumeral joint only, some of them are for scapula, which means if it's a 2-to-1, then 60 degrees is scapula, and 120 degrees is humerus, right? Okay, we good? All right. Scapular plane. Everybody knows what the scapular plane is. Can anybody tell me what it is? Adeline, what's the scapular plane? Describe it in words. Scaption. Adeline, are you with me? Are we?
It's on a 45-degree angle.
Okay, so the scapula, sort of, yeah, it's on a 45-degree angle, but can anybody be a little bit more specific? Marissa? It's midway between the frontal and the sagittal. Yes, yes. Plane of scaption. And why do we have that scaptional plane? Because of where the scapula sits, right? Scapula sits at a at a 30-degree angle. Doesn't sit flat on the rib cage, right? I mean, I think we went over this enough. Okay. So scapulohumeral rhythm. I'm trying to get this to. And what's a force couple?
That's where the muscles are held.
Muscles working in different directions to pulling in different directions to produce one action, right? And we said an upward rotation of the scapula involves what?
Upper trap, lower trap, serratus anterior.
Upper trap, lower trap, and serratus anterior. Downward rotation involves what? Rhomboids. What else? Pec minor. Levators. Okay. All right. So we came to dislocations, and we said the most common. I'm trying to get this to. Where's my? Here's this slideshow. Oh boy.
I think I've got a slap there. Yeah, it was.
All right, so if I said here's where we left off, right? We said shoulder dislocations occur which way most commonly? Anterior dislocations, and if we have recurrent anterior dislocations, what might happen? We could have a labral tear at the inferior part of the labrum. We could also have a bony Bankart, which means that the bone is being pulled off inferiorly at that area. And we could also have what's called a Hill-Sachs lesions, where when the humerus comes anteriorly, it abuts the acromion, the glenoid, and it produces a dent or an indentation, and some people call it a fracture. This you'll see an indentation known as a Hill-Sachs lesion. And this, we didn't look at long enough. But I did add something else to it, and it didn't save, I don't know why. But let's just look at this one more time, because it'll be in slow motion, and see it come forward. And as it comes forward, there's the head of the humerus, right? It keeps going, keeps going, keeps going, boom. There's your Hill-Sachs lesion. Okay? So as it continually dislocates and moves anteriorly, the posterior part of the humerus develops that dent, Hill-Sachs lesion. Okay?
So if this occurs repetitively, does that mean that it's the problem with the muscles, the five muscles that are surrounding?
As the shoulder becomes unstable. So if you have an anterior dislocation, sometimes you have a tear of ligaments. Sometimes you also have involvement of muscles where they become weaker or torn or stretched. Or you could have a biceps that's involved. You could have other muscles that are involved.
For something like Hill-Sachs, does it have to be only, is it full dislocation or can it happen with subluxation as well?
It happens with a dislocation. Subluxation. All right, let me get out of this. Escape. Right? I just escaped. Why isn't it working? Guys! All right. So Hill-Sachs deformity. The slap lesions proximally, so what's happening, it's happening proximately, and we're having the superior labrum is affected. Superior labrum is torn. Usually also happens with anterior dislocations. We saw what the labrum looked like. What is the labrum? It's fibrocartilage that surrounds the glenoid itself, and what it does is help provide greater surface area or helps provide a deeper seat for the head of the humerus because it's very shallow. So something needs to hold it there besides the muscles. Okay, so we talked about the bank part, bony bank part, slap. Slap just means superior labral and an anterior, anterior posterior direction. Okay. Bicipital tear. You could have a bicipital tear where the long-headed biceps ruptures off of the supraglenoid tubercle, and as it ruptures off the supraglenoid tubercle, it falls down into the arm. Sometimes it looks like a Popeye's deformity, even though Popeye had a forearm that was huge. This muscle just falls down into the arm itself, into the upper humerus. From usually associated with a throw of some sort or some kind of a forceful activity. I think I told you guys about my uncle who was a bowler, and he was a bowler for a league, and he was very good at bowling, and he bowled one day, and he came home, and the next day he said to me, I got this something funny in my arm, and he asked me to look at it, and I said, looks like you ruptured your biceps, and blah, blah, blah. He said, I don't like how it looks. And I said, well, you're going to go to the doctor, and he's going to tell you there's really nothing. He was in his 70s. There's really nothing you could do for it unless you want it tacked back on, and, you know, that's surgery, and I don't know if you want to really do the surgery, because there are other muscles that do what that does. He said, no, I don't like the way it looks. The women aren't going to look at me because they're not going to like how I look. So he went to the doctor, and he calls me up, and he says, you know, it cost me $200 for him to tell me he can't do anything about it. I said, well, you should have paid me the $200. But really, they didn't do anything about it. He didn't get it attached or anything like that, and, you know, over time. But there are the muscles that do, luckily, what the biceps does. So, scapulo, let's see, where are we? I don't know, I don't even have this up here. Scapulothoracic problems, winging of the scapula, paralysis of what nerve? Long thoracic nerve, because a long thoracic innervates the serratus anterior. You learned that today and yesterday, right? Serratus anterior originates where? On the outer border of the first 8 ribs, inserts, goes around posteriorly underneath the scapula. On the medial side, inserts into the medial border of the scapula. What does the serratus anterior do? Protraction, right? Also associated with stabilization of that scapula. What else does it do that's really important? It's an upward rotator. So it works along with, as a force coupled with the other 2 muscles, are upper trapezius and lower trapezius, to upperly rotate the scapula. Without serratus anterior or palsy of the long thoracic nerve results in your inability to raise your arm completely over your head. Your left at about 120 degrees of flexion. Okay? So that's what you would look like. As I told you, some people believe, especially in these movement courses, movement disorder courses that are out there, Shirley Sorma courses, they're really excellent. She actually believes that the winging of the scapula can only happen with palsy of the long thoracic nerve. However, people do have weakness, and over the years, they have described this, and even your book has described this as an internally rotated scapula, when the scapula appears to be off the rib cage. But there are other things associated with that. They have to be a little bit further away from the spine itself. Okay? So here's your serratus anterior. If you lose motion, or you have a problem with the serratus anterior, or you have an axonmesis or something that's associated with the nerve not working, then you can only lift your arm 120 degrees. All right. So suprascapular nerve. Suprascapular nerve innervates the supraspinatus and infraspinatus, which you guys haven't had yet. But you could recognize that there is a supraspinatus, and where is that? It's part of what group? The rotator cuff. So supraspinatus, suprascapular nerve, you remember from your brachial plexus. What's the nerve roots? C5 and 6, right? So where's the sensory pattern associated with that? C5 and 6, dermatomes. So where is she complaining of numbness?
In the lateral
Lateral.
Arm and lateral forearm, right? She did. What do you see there? This is a real patient. What do you see there? What do you see?
It's an internal rotation.
You see her shoulders depressed? That's what you're saying? What else do you see? What else do you see?
Is there internal rotation?
Just observe. What do you see? You see her bra, right? Do you see her bra strap? Do you see where the bra strap was?
Yes.
Okay. Do you see the indentation where the bra strap was? Okay. What is located there?
The
AC?
strap
AC's on
supraspinatus.
What is located there? Andrew? What part of the scapula do you think that is? I'll give you a hint. It begins with an N. Superior notch. Okay. What's over the superior notch? Transverse scapular ligament. What goes through there? Suprascapular nerve. That's why she had numbness. What was my therapy? Get a better bra. She happened to be very, very large. So, over the shoulder boulder holder. You've heard that terminology, right? She was like here. So what did she have to do? What did she have to do? She had to go get fitted specifically for a bra that had large white straps or something that crossed in the back that kept her where she needed to be. Right? That's what she needed. But she went to a few doctors who said, oh, you have a neck problem. We're going to send you for an MRI. We're going to send you for this. Nothing helped. This is what she had.
So another example of look at the everyday patterns of their life.
Look, but you got to observe. That's why I asked you, what do you see? What do you see? It's no magic here. The magic is what is under there. You know the anatomy. So, does it make sense to you? You start touching around and she says, I don't feel it, I don't feel it, I don't feel it. Where do you go? Well, I have to go to a nerve or something, right? I mean, a nerve does make you feel something, yes? So it can't be that she just had nothing wrong with her, or that it was in her head. Okay. All right, six muscles. Six muscles, supraspinatus, that's really, really an important muscle. Right, it initiates abduction, but it's important. All of the cuff muscles are important for sitting, keeping the head of the humerus in the glenoid fossa, and also depressing them. and preventing the upward or counteracting the powerful, powerful pull that's provided by the deltoid. Because if the deltoid is working and your cuff muscles are not, then you're going to have superior migration of the humerus. And you're going to wind up with subacromial impingements and everything else. Okay? And eventually, you know, as time goes on, maybe even cuff tears. Okay. And the long head of the bicep becomes very, very important when you're going past 90 degrees of flexion. We categorize muscles also by where they are and where they go. Suprahumeral muscle means what? I'm sorry, scapulohumeral. Scapulohumeral muscle means what? It's originating on the scapula and it's inserting into the humerus. Could you see this as a quiz question? Identify 2 or 3 scapulohumeral muscles. Yes? You getting it? You understand it a little? Okay? So the deltoid, supraspinatus, infraspinatus, teres minor, subscap, teres major, coracobrachialis. You see they're not really large, huge muscles. I mean, they're muscles, but they're not your huge muscles. They're not your axial humeral muscles. But nonetheless, you need to know them. Your scapulohumeral muscles. Axial scapulo. These are coming from the axial spine. That's why you guys have to know where the axial spine is. So the ribs and the sternum, is that part of your axial spine? Remember when we started this, we said we had axial and appendicular were the limb girdles and the legs and the axial spines, everything else, right? And the arms, I should say. So the axial scapula, pec minor. Where's the pec minor originate? You had it today? 3 to 5 ribs, 2 to 5 ribs, 2 to 5 ribs. Inserts where? Coracoid process, right? Trapezius. C7, nuchal line. Spinous process T1 through 4, 5. Spinous process T6 through 12. Inserts where? Lateral third of the clavicle. Acromion spine of the scapula does what? This. Does this. Like you do. I don't know. That's what it does. You guys are really good with your upper traps. So it does this. As a force couple, it upwardly rotates. It retracts the scapula. Depresses the scapula. Does a lot. Rhomboid major and minor. So they're coming from the spine and they're going to the medial border and the root of the scapula and they're downwardly rotating the scapula. Important for that downward rotation. What's on top? The major or the minor? The minor. The major always carries the minor. So the minor's on top of it. Levator scapula. Not the elevator scapula, but the levator scapula. It tells you what it does, right? It raises the scapula. It's also a downward rotator. And the serratus anterior. Okay. Axial scapula. Axial humeral, you see, there's 2 big ones. I'm going to ask you a question about, I'll ask you later. Steve, not Steve. No, Steve, never mind, I'll ask you later. But a pectoralis major and latissimus dorsi, if you look at somebody from the side and they lift their arm up, or you take a cadaver dissection, and you pick a cadaver's arm up, you're going to see huge muscles, one on this side, one on this side, cutting you from anterior to a posterior direction. Large pectoralis on this side, large latissimus on this side. They do a lot of things because they're very large muscles. And they're coming from the axial spine and they're going to the humerus. Both of them, by the way, going to the bicipital groove of the humerus. Okay? You good with that? I always forget you over there. So latissimus dorsi and pectoralis major. We won't do these, because you don't need to. I mean, these are origin insertion of these muscles. We don't need to do this now because you're doing them in lab. Right? Oh, and actually here you could see I actually put the origin assertion, because you guys did the trap yesterday and you didn't separate it, right? So please look at this
We
to
did.
separate it.
We did.
You separated it?
Yeah.
Okay, so please look at this to separate it. So it even says here what I said, it's a forced couple of the upper and lower work with the serratus to provide upper rotation of the scapula. All right, rhomboid, major, minor, levator, serratus anterior, pec major, latissimus dorsi. Okay, this is another thing that I don't think you guys had yesterday, that's why I put it here to remind myself. Latissimus dorsi not only is a strong adductor, internal rotator, and extensor of the humerus, but it also extends the lumbar spine and flexes the thoracic spine. Okay, so it also does that. So please put that down in your notes. In fact, when latissimus dorsi is tight, and you do a length test of latissimus dorsi, when you get somebody down on the table, you ask them to bend their knees because you want a posterior pelvic tilt. When you raise their arm up, if they don't do the posterior tilt and they have a lot more range of motion, and then do the posterior pelvic tilt and they don't have the range of motion, you know that there's shortening of latissimus dorsi. Okay, but that's for next semester. Okay, here we go. Disorders of the PNS. So we have a neuropraxia. Neuropraxia, basically, you see that it says it's local blockage and it interferes with conduction. Basically, it's a nerve compression. All right? And that nerve compression is usually due to some kind of a pressure. It's commonly known as a compression. We have something known as Saturday night palsy or Bell's palsy. Bell's palsy we know is transient. It should be transient. It comes and goes. Transient means it comes and then it leaves. Saturday night palsy, same thing. They call it Saturday night palsy, and I think I have a picture of it because, and I also told you guys that if you're leaning over a chair, or then they called it Saturday night palsy because they said, you know, people leaning over a bar stool, talking to some nice young lady next to them, or a nice young lady talking to some nice young gentleman, may have compression of the brachial plexus and wind up with, because they stay in that position for too long, a problem with nerve conduction. Other things that I could tell you about something neuropraxia, if you sit and you bend, you cross your leg. You guys ever cross your leg for a long period of time and then get up, and when you walk it feels numb, your whole leg feels numb, and somebody tells you, oh, I remember that used to happen to me as a kid. My mother said, you lick your hand and put it behind your knee and it makes it better. I don't even remember if it works, but I remember that was kind of the right, she said it was the right place to be because I had neuropraxia of sciatic nerve. So you have a neuropraxia when you go to sleep at night and you sleep with your hand over your head and you wake up and you think you had a stroke, or it wakes you up and your fingers are numb and you have to shake them out. You're looking at me like, you ever
Yes.
feel that?
Oh,
Okay,
yeah.
all right.
Get on the
So-
toilet, too.
So that's a neuropraxia.
Start reading the shampoo bottles.
An axonmesis involves a lot of structures like the epinorium, the perinorium, the endonorium, the covering of the nerve itself. So it's characterized as disruption of the axon. This is more associated with a crush injury. So it's a crush injury, and you're left with preservation of the supporting connective tissue. So that results in degeneration that's distal to the injury. Remember, we're talking about peripheral nerves here, because does the central nervous system have any neurolemma? No, so we don't have regeneration in central nervous system. So the peripheral nervous system, we do have regeneration. So you get regeneration distal to the axon of the nerve that's the degeneration is associated with. So it's more associated with nerve crush injuries. Okay. And in neuromesis, this is the worst of all of them. This is a complete nerve transaction. All right? So you get a complete severance of a nerve, disruption of myelin sheaths, the axon, the surrounding connective tissue, etc. And sometimes you get degenerations of the axons. You're lucky if these axons have regeneration. You get regeneration of them, but you're lucky if they actually meet the other nerve, because the transaction is complete. So this is the worst, and sometimes, and I have a picture of it. Okay, so here's neuropraxia. and you can see that here's the outer endoneurium, and everything's okay, everything's connected. Now we have here where the connective tissue is still supported, but we have a crush injury, and we get regeneration because everything's still intact. So that nerve is still intact, peripheral nerve is still intact. And the nerve regenerated at a rate of 1 millimeter a day. Okay? 1 millimeter a day. So if the injury's up here, then it's going to take quite a long time before you have movement here. If the injury's here, it's going to be a lot less time.
I was wondering what's the difference between neuromesis and
Neuromesis?
yeah, that and ALS. Isn't it like the same thing, like regeneration of like the nerve or?
Yes, but it's different because it depends where it happens. There are some that happen at the neuromuscular junction. You don't get a complete severance. This is a cut. This is somebody takes a machete and they cut it. You know, it's different. It can happen at the myoneural junction. It could happen in the plaque. It could happen in the brain itself. ALS is a lower motor neuron problem. You'll learn about that. That's different. Okay? So a neuromesis is you get degeneration, you develop a neuroma, and you can see from this picture here that as these nerves, where's my pointer here? As this nerve will start to regenerate, you see this is regenerating but the nerve is intact. Now this is starting to regenerate, but it has to find its way down to here. So you're lucky if it does, and you're not lucky if it doesn't, right? Because if it doesn't, then they're going to need some kind of surgical intervention to go in and try to transpose nerves from other places, or try to do some kind of intervention to make. That's what happens when somebody cuts your arm off. You know, like I worked inner city for a long time, and I told you that I saw horrible things. And one of the things, the woman had her arm cut off with a machete, and it was in the other room, and her grandson brought it to her, and so then they brought it into the hospital, and they reattached the hand. She didn't get any movement, but she had a hand. But you know, I mean, aesthetically, she liked the fact that she had a hand, but it just never worked. Yeah.
You say that regeneration is possible without surgery?
You're going to get regeneration from here. These nerves are still going to regenerate, but I don't know if they're going to be able to make it down to wherever that nerve was cut. They just may be cut and hanging out here somewhere. That's what happens a lot of times when you have phantom pain. It's because the nerve, like they cut the nerve. Where does it go? You know, it was used to go into a muscle. Now it's just kind of flapping around there. So it's still recognizing the fact that it has somewhere to go, but it just doesn't go.
Wow.
So neuropraxia, axonmesis, neuromesis, the worst of the three is neuromesis, and regeneration occurs at 1 millimeter a day. Okay? Radial nerve palsy, radial nerve injury from acute trauma or compression of the radial nerve. One of the things that was in your quiz today, how can you compress the radial nerve? We talked about this when we talked about the brachial plexus, by the fact that the crutches are too high.
That was your marathon?
All right, crutches are too high. Compression of the radial nerve, which results in what? Wrist drop.
Yeah.
Wrist drop, right? You forget that? Wrist drop, radial nerve. So, Saturday night palsy, it says here, alcohol might be a factor. Not that any of you would know about this. But their arm is over the chair and may be compressed. I had a guy that had a complete brachial plexopathy because he was a drug addict. And he started to vomit, and he put his hands over the toilet bowl. And he was there for 8-10 hours. So he had compression of all of the brachial plexus. So when he walked in, he couldn't move anything bilaterally. But he did get returned. It took an awful long time. Honeymoon palsy from another individual sleeping on your arm. You know, you put your arm around your girlfriend. I say girlfriend because by the time she's your wife, you've got a king-size bed. Right? So you put your arm around, somebody sleeps on you, or you even just sleep with your head, or you sleep on your side, or you sleep on your stomach, or you sleep with your hand like this, and you have compression of that. And also you have radial nerve palsy when crutches are too high and they're in the axilla. Erb's palsy now. This is compression of the upper upper trunk of the brachial plexus, C5 and 6, upper root, resulting in a waiter's tip sign. Waiter's tip sign means this, right? Why? Anybody know?
Sneaking some money.
Anybody know? What position is my shoulder in?
Internal rotation. Extension.
What position is let's analyze this. What position is my shoulder in? What do you see?
Extension.
Extension of the shoulder. What do you see with the elbow?
Is it hyperextension?
I can't hyperextend it if you paid me. Extended and what?
Oh.
Extended and what?
Pronated.
Observation, guys. I'm not asking you for magic here. Pronated, right? My wrist, extended, yes? Flexed, right? Waiter's tip sign, you know, you walk into a place and you want a special seat. Waiter's tip sign? Okay, that's a waiter's tip sign. Why is the arm at the side? This is congenital. Person was born with it. Child was born with it. Brachial plexus was stretched. Had a stretch injury to the brachial plexus. Why is the arm at the side, Andrew?
Can't abduct the shoulder, they can't extend the wrist.
Why is the arm at the side? Because the shoulder is extended? Why? Anybody know?
I'm gonna say something wrong with the radial nerve. I'm just
Chris?
This is the myotone for C5 abduction. So-
Because the myotome, thank you. Myotomes. Jesus, somebody's listening. Myotomes. Myotomes are muscles. We did dermatomes. So, you know, maybe myotomes should be on this quiz on Thursday?
Yeah.
Thursday or Tuesday?
Oh, yes, it's-
Myotomes? Myotomes associated with C5 and 6 are what?
Abduction for C5.
Deltoid and biceps, C5 and 6. So I can't abduct the arm, and I can't flex the shoulder. Why am I pronated?
That's the radial nerve.
Biceps, right? C5, 6, biceps, pronated. Why is my wrist flexed and not extended? What extends the wrist? C6. So, can't be counterbalanced with flexion and extension to keep the wrist in neutral, so the wrist is flexed because we still have C7 going on, right? Yes? I hope this is becoming a little bit more clear. I know to some of you it is. Got a lot of reading to do, guys. Okay. Klumpke's paralysis, compression of, stretching of the lower brachial plexus, resulting in a functionless hand. Why? Oh, this might be a little bit more difficult, but functionless hand. CAT1, what are the myotomes for CAT1?
Medial.
Flexion and abduction, right? So I will tell you that CAT1 are the muscles we're talking about, lumbricals. You haven't learned them yet. We're talking about lumbricals. We're talking about interosseis. The interosseis are the abductors of the fingers. We're also talking about CAT1. What else is involved? Median nerve, right? So we wind up with hyperextension of the MCPs and flexion of the IPs. So you wind up with something like that. That's a claw hand. Functionless hand. Klumpke's paralysis. Okay? Not as common as Erb's palsy.
Professor,
Okay? Yeah.
out of curiosity, what's the difference between palsy and paralysis?
Same. It's used in
So it's the name.
Yeah. But it's known as Klumpke's paralysis or Klumpke's or Erb's palsy. It's the same thing. This is just somebody who named it, but it's paralysis. It's not innervating, and then it's resulting in some kind of deformity. Okay. We talked about what a bursitis was, and we said a bursitis was this fluid-filled sac, and we also said that the pain is intense, dull, achy, throbby, hot. So you put your hand over the area, and you never put this part of your hand over anything when you're assessing it. Because this part of your hair, the palmar surface, is very, very highly vascularized. Okay, so you use this side. You test somebody's temperature, you assess them for, is it warm? Okay, can somebody have a bursitis and a tendinitis? Absolutely. So you're going to assess for warmth. You're going to look for edema. The patient says it's hot, I can't sleep on it, it throbs, it's painful in all directions. Okay? The most common is the subdeltoid and subacromial, and the least common, because there's a lot of bursa all over, and the least common is the subscapular bursitis. Subacromial bursitis is very common. Tendinitis, we said, was an inflammation of the tendon. And we said with rotator cuff injuries, supraspinatus was primarily the culprit associated with that. Overhead activities, and this pain is sharp. You have twinges. It hurts when you do things like put on a jacket, put on a bra, throw your money into the toll. Yes.
For rotator cuff tendinitis, would you avoid overhead activities or strengthen and correct the form of overhead?
Okay, what you do with a rotator cuff tendinitis is you have to, if it's truly just a tendinitis, what you have to do is you have to get rid of the inflammation. So how do you get rid of the inflammation with specific modalities, etc.? You could do like iontophoresis, or you could do ultrasound, you could do a deep friction massage, etc., etc. Once you get rid of the inflammation, you need to work on stretching. You need to restore the function. So, and it depends on what the tendinitis is from. So, okay, and it's an overuse syndrome usually. So, yes.
It's 1250, just one second.
Oh, is that what you're telling me?
No.
What's your question?
Even if it's slightly painful, you'd still want to use some passive range of motion, right, to promote circulation, so it doesn't stiffen up in the example you were talking about.
I wouldn't. If somebody had a rotator cuff tendinitis, I wouldn't do passive range of motion on that person unless it was long-term and they really weren't moving and it started to freeze. I mean, if somebody's got pain, they're going to stop using it in some directions, but they'll still work around it. Like we'll talk about specifically if it's supraspinatus tendinitis, you start to develop a painful arc of motion and you'll get out of that arc. You'll still have the full range of motion, but you'll try to clear the greater tubercle from the acromion by doing this, and you'll still get full range of motion.
You gotta wait a little while.
Yeah, because that's really inflamed. If somebody's got truly, really an acute inflammation, they're not going to want to do anything. Yeah, and it's not going to last that long anyway that I'm worried about having a frozen shoulder. It's those people who never come and stop using it and don't have to do overhead activities that wind up with something like that. But they won't come to you unless they're really hurt.
Right.
All right?